There you go. Can you guys see my screen and hear me okay?
Yes, I would just go full screen. Perfect.
Okay, perfect. Alrighty. So good morning, everyone. My name is Aik Sanabia. I am the Sports Medicine Fellow at Rutgers. Today we'll be talking about the paper, The Effect of the Corticosteroid Injection into the Rotator Cuff Interval for Early Frozen Shoulder by Dr. Sun and his crew in 2018. So the freezing phase or adhesive capsulitis has a total of 3 overlapping phases. The freezing phase is characterized mostly by significant pain, as well as an increased, decreased, worsening passive range of motion. The rotator cuff interval has been shown to play some kind of role in the freezing phase, with histological findings showing chronic inflammation, proliferative fibrosis, increased vascularity and nerve tissue, which is believed to be attributing to the pain and the stiffness during the freezing phase. The most common treatment is an intra-articular injection. 40 milligram dose of steroid has been shown to be the most efficacious. Because of the histological evidence showing that the rotator cuff interval does have a role in developing full-blown adhesive capsulitis, the researchers of this group decided that, hypothesized that a steroid injection into the rotator cuff interval could potentially yield better results in terms of pain relief, increased range of motion, and function than an injection into the interarticular or the subacromial space. The study design was a random prospective controlled trial. Participants were randomized into 3 treatment groups by overall 2 blinded physicians, one allocating the research and the other actually doing the randomization. The injections were standardized. They used the same length needle. They used 40 milligrams of triamcinolone with 2 milliliters of 2% lidocaine. All injections were done under real-time ultrasound. The physician performing the injection was not blinded, and that's because of the techniques used during the injections. And it's a statistical analysis was also done in order to determine an appropriate sample size in order to decrease type 1 error. The treatment approaches were that the intra-articular injection was done through the posterior aspect of the shoulder with the subacromial and the lateral, and the rotator cuff interval did have an anterior approach. I'm just going to very quickly show some pictures of what that looks like in the papers. So here on the left is a picture of a sagittal view of the rotator cuff interval. This was the anterior approach taken by the provider. This would be the interarticular approach coming in through the posterior shoulder, aiming for the labrum. And then this would be the lateral approach used for the subacromial injection to go through the deltoid into that subacromial space. The inclusion criteria were men and women ages 18 to 70. They had to have a primary diagnosis of frozen shoulder, as well as normal x-rays, and the shoulder was supposed to be in a freezing phase. Now, in order to ensure that the shoulders were in the freezing phase, it was characterized by having a loss of passive motion in at least 2 directions by greater than 30 degrees. The duration had to be less than 9 months, and the visual analog score of pain had to be greater than 7. So that's our 1 to 10 score with pictures at the bottom, and I'll show a picture of that later on. The exclusion criteria was any secondary cause to shoulder stiffness, if they had bilateral freezing or frozen shoulders, any shoulder that was not deemed to be in the freezing phase was not included, and any shoulder that did have a steroid injection within the past 3 months or a contradiction to injections were also excluded. They did quite a few statistical analyses. They did an ANOVA in order to compare the 3 different injections. Following that, they did a post-HOC Fisher least significance difference in order to compare 2 of the 3 in the ANOVA test to ensure significance. They also did a chi-square test for binary variables, and a p-value was determined to be significant if it was less than 0.05. So overall, they had enrolled 136 patients. 39 were excluded based on the exclusion criteria, and then a couple were lost to follow-up, with overall 27 participants in the rotator interval injection, 24 in the intra-articular injection, and 26 in the subacromial injection group. Like I said, primary outcome was pain, and this was using this visual analog score. Secondary outcomes were a constant score. The constant score takes into consideration pain and range of motion. It's the patient's perceived ability to carry on daily life. It is a score out of 100, so the higher the score, the better the patient actually feels. The DASH score, on the other hand, is used to perceive a patient's disability. It also takes into account a patient's range of motion of pain. It's also scored out of 100, but the higher the score, the more disabled the patient feels. The passive range of motion was done by goniometer, and the internal rotation was done by vertebral level, with each vertebral assigned a number. A blinded independent physician collected the data points at the four different time points after each injection. The first results given by the authors were meant to show that the population in each group were not significantly different from each other. And as you can see, the p-values are greater than 0.05. And so therefore, there was no significant difference between the three groups. This part of the table, which is table 2, takes a look at pain scores for each group, as well as passive range of motion, and if there was improvement or not during each time interval. Also takes into account the constant and the DASH scores. The main thing that I want you guys to pay attention to is that the rotator interval and the intra-articular injection do seem to improve, but it's very interesting that the subacromial injection, even though it did have improvement in pain scores on the pain VAS, so the first column, it did have a decrease in range of motion. And interestingly enough, the scores with the constant and the DASH do seem to be going into the right direction, meaning that the patients seem to feel as if they were getting better. So it is interesting to note that there was a decrease in passive range of motion in that subacromial injection group. The p-values all the way to the right, so the group by time interaction, that was done to show that there is significance in the data. So what this will tell us is that even though the data is occurring at different time points, there is actual significant difference in pain and range of motion in each of the groups, but it cannot tell us which group was superior. In order to figure out which group is superior, you would have to do a post-HOC Fisher least significance difference. And this would be the one where you would compare two groups at a time and figure out who is more significant. As you can see in this table, there was no significant difference at the start of each group. And the post-HOC test did suggest that the rotator cuff interval was most efficacious, followed by the intra-articular injection and then the subacromial injection at the end. And pain did seem to be significantly less in the rotator cuff interval injection versus the other two injections. So those are the main takeaways. So pain and passive range of motion was most efficacious after the rotator cuff interval injections. Table 3, it compares each intervention with its time interval. Overall, as you guys can see, the subacromial injection does not perform as well as the rotator interval injection or the intra-articular injection in regards to pain and passive range of motion. Interestingly enough, there was no significant change in the DASH scores, and that's the level of perceived of impairment from each patient. So that was very interesting to note when comparing the three injection sites. So that would be the main takeaway from this table. So overall, the results do show that the rotator interval injection was the most efficacious, followed by the intra-articular injection, and last but not least, the subacromial injection. Pain was more quickly relieved with the rotator cuff injection versus the intra-articular injection, and at the very end, the subacromial injection. Improvements did last up to about 12 weeks, and the constant scores also showed that there was a significant improvement in that rotator interval group versus the other groups. And the DASH scores does also show reduction in perceived impairment in all patients, but it was not actually significant in the subacromial group. In terms of discussion, it's very interesting, as I mentioned, that the subacromial group did have less pain, but had worsening range of motion. The authors do attribute that to those participants' shoulders moving from the freezing phase to the frozen phase. Some pluses of this experiment is that they did attempt to ensure that the shoulders were in the freezing stage by their exclusion and inclusion criteria. The potential additional intervention of avoiding the same location in order to avoid malinjection and ultrasound guidance as well per injection in order to safely say that yes, the results from the rotator interval injections were most likely because of the rotator interval injection. And so having those 3 different anatomical sites I thought was very important. All injections, as I said, did use that ultrasound guidance to ensure that the injections were going into the appropriate anatomical space. And it was interesting that they did calculate the sample size needed in order to decrease that risk for type 1 error. Some limitations to the study is that it's mostly patient reported, and the duration of the symptoms is also patient reported. The rotator interval injection may not totally prevent leakage into the intra-articular space, and physicians performing injections were not blinded to injection protocols. I understand why not, but it does add a little element of bias, and an official control group was not set. And it would be interesting to have further randomized trials with the intra-articular injection serving as a positive control, as that is, as of right now, the most common injection used for adhesive capsulitis. So that's pretty much the paper, and I will turn it back to Dr. Monaco. If anyone does have any questions, feel free to put them in the chat.
Just hang on 1 second. All right. All right, you can all see my screen again, right?
Yes.
All right, great. All right, sorry about that. Just working on a little technical issue real quick as we set up our demo of this. So thank you again for that presentation. I'm going to launch the poll, kind of get feedback from everybody on the article and their thoughts on that. So fill that out. If you have any questions and answers, put them in the Q&A, or you can use the chat feature on that as well. As you look at the poll questions, I want to review quickly some of this anatomy for this region, and then we'll set up to give a demo in the last section of this. So the rotator interval is a bit complex anatomy. I want you to start thinking broadly about what this is. We have this subscap coming in purple here, we can see the rotator interval coming uh, from the coracoid, with the coracohumeral ligament coming down and encompassing over the biceps and between the supraspinatus and the subscap. So coracohumeral ligament, which is the big structure in the rotator interval, coming down between the subscap and the supraspinatus. Here you can kind of see the angle of it as well, coming from the coracoid to the humerus here. And note also the coracoacromial ligament, which would be another ligament that's going to be running at a different angle, which we want to look at, particularly for impingement. So this kind of gives you an overview of how that ligament runs on that. Seeing it more broadly, the ligament run again from the coracoid, coming down and enveloping the bicep and sitting between the subscap and that supraspinatus here. The superior glenohumeral ligament is going to run underneath the CHL, and we'll take a look at that. The best ways to look at this will be shown in the demo, but for a transverse view will be the modified Crass view. This longitudinal view, I like to do a little bit of external rotation. You can measure the thickness of the ligament, but it can be difficult exactly where you do your measurements, and it's pretty subtle sometimes, the differences. The ligament will be lax in internal rotation and tight in external rotation, so we usually do a little bit of external rotation to see the ligament better. This is what it kind of looks like with the ligament coming across here with the CHL up top, CHL here, and the CAL, sorry, coming up top, coracoacromial, making an arch, which is used for subacromial impingement, and the CHL coming in, CHL coming in, coming across here. A little bit of external rotation and the shoulder and retroversion is helpful. When we look at it in a transverse view, this is going to be the easiest view, but there will be some anisotropy. We're going to look and find that bicep tendon, and then we're going to look for the CHL sitting up top. Now, the CHL has a lateral and a medial branch to it, so I don't really kind of define those, just do it as a whole CHL complex with the SGHL sitting below. The subscap is going to be sitting more medially, and the supraspinatus laterally. So you're going to look for the bicep tendon, and then look for the structure sitting above it, and then a structure sitting below it on the medial side near the subscap for the SGHL. And what does this look like, again, schematically or anatomically? CHL sitting up top, biceps, SGHL below, and you have your subscap and your supraspinatus on that. And remember, there's going to be a lot of anisotropy here. So you have to do tilting of the probe. You'll see the bicep here. And then when you tilt the probe, you can see the CHL kind of sitting above it, sitting above that bicep, with the supraspinatus sitting more laterally, and the subscap sitting medially, and the SGHL sitting underneath. So this is CHL, SGHL with anisotropy. Now you can measure the thickness in adhesive capsulitis. Sometimes it can be subtle. Here we see a very small CHL, and here pretty thickened on that, but this can be subtle. You have to do side-to-side comparisons. Really, it kind of adds to your clinical picture. It's not just a feature that we can kind of hang our hat on as just isolated CHL thickness. In the early stages, when you're freezing, you can see a lot of positive Doppler, and this is very, very sensitive and specific. Study by Lee noted around 95% specificity when you see Doppler going on around the CHL and SGHL. It's better seen early than late stages, but when you do see this, you're pretty certain you have a fair amount of inflammation causing adhesive capsulitis going on. So what are are injection options in adhesive capsulitis. From this article, we read about the CHL, and this is primarily what I like to do, particularly in the early stages when they have inflammation on that. The pros of this is that you're addressing the pathology where the inflammation is. The downside is you're injecting a ligament with a steroid, and some people have some questions about long-term, whether that's a good idea or not. And you can make arguments, and we really don't have some studies that tell us it's doing any problems, but it does make some sense to kind of not use excessive amount of cortisone around a ligament. Some people will inject the joint, either anterior or posterior, and we'll talk about the injection technique for this. On that, the study suggests the anterior injection is better than the posterior. Some people will do a large volume posteriorly and try to loosen up the joint as a technique, hydrodilation or volume injection of the joint up to 30 mLs. I don't prefer to do this. I find that since I've done the anterior injection of the CHL and or the joint, we don't need to do these large volumes posteriorly. Some people will do a subacromial, but there's little value unless there's bursopathy. And some people will do just a suprascapular nerve, either distal or proximal block, to kind of reduce their pain on that. And that can be helpful, but I prefer to go where the pathology is on that. And here's kind of the injection technique, which I'll demonstrate a bit here without obviously the needle, but this is a good injection. It's easy to do when you're in the right position because you can inject a few different structures. You can bring your needle in and inject the bursa sitting up top here and put a little bit in the bursa. Then you can come down into the CHL here, and then you can even come down to do a joint injection by either coming around the biceps or just below the biceps on that to inject. So this, we can do a 3-in-1 injection. We're doing subacromial, CHL, and joint all through one position. And that's why I prefer this approach. It tends to work well, and we're able to get multiple structures to get the patient some relief on that. I mentioned before the different injection techniques. You certainly can do the posterior injection, but the anterior joint has been shown to be better in some more recent studies. So I encourage you to think about this as your approach on that. In the future, people are already starting to do some sonographically guided releases of the CHL. I think we need more work on this, but people have been starting to do it. There was a paper on 10X with it recently on that, and a prior paper using just a regular scalpel to release it. So there can be tools done, and this might be something in the future for recalcitrant adhesive capsulitis instead of surgery, but further work needs to be done on potential problems by releasing this and any long-term problems from that. Let me release the poll here and go over the results there, and then we're going to set up to do the demo in a second. All right, so just looking at the poll here, ultrasound plays a key role in diagnosis of AC. I think it can, but I think the key here is that it rules out other things going on that can be associated with AC. The diagnosis of AC through ultrasound is challenging. It's more of a clinical diagnosis, but the ultrasound certainly can help and help us with guidance. But you have to be pretty experienced to really definitively diagnose AC with this, unless you're seeing the Doppler and other things. It takes some training to do that. Do you currently use ultrasound for the diagnosis? It's kind of mixed, and most people know. And so think about using it and get some experience with it. As you do more, you'll get better at seeing it as you see these cases. At what stage do you think injection is best? The early stages, that's correct. The study suggests that pushing patients to inject it early will probably give you better results, particularly the CHL. If you do it later, you tend to sometimes have to do the joint injection and try to loosen up the whole process. So think about doing it early. Where do you think it's best to inject? So about a third of us think posteriorly. Not many are doing the CHL. A lot of people are doing the combo. So this is kind of kind of what we're going to talk about a little bit as we demo this. And then not many people have done this injection yet. So if you have cadaver labs, it's good, or work with your attendings on this, on that and that. All right, so I'm going to go right to the demo here and get this set up. So bear with me for a second. Yeah. It's not open yet. Okay, should come up now. Just close this. Okay. Hang on one second.